Can you see my screen, please? Just write me. Okay, perfecto. So, it's pretty sad these days that we will have to teach ourselves how to deal with basically a dirty bomb or a nuclear attack. So, the way to deal with such explosion, first of all, the first step to deal with it is actually cleaning your body. How is the cleaning your body goes by? Okay, so yeah, now we are speaking about something like this. So in case of a dirty bomb, in a dirty bomb, you should clean your body. How to clean your body? First step, take off all of your clothes. Wash the patient with a lot of water. I'm not speaking about a bucket of water. The recommendation says 500 liters. That's plenty of water. Okay, you cleaned yourself. You should consume something, which is which medication you must consume to prevent papillary thyroid of the cancer. Iodine. Okay, so is it the same as there is the iodine tablet and there is the iodine that we use for wound. Which one should you use? The tablet. Okay, guys, let's be real with each other. In case of real war, will you find the tablet in the pharmacy or everybody else will find it? Exactly, it will be depleted, you will not find it. So today I'm going to teach you how to make it at home. I know this is not your typical class, but this is an extraordinary time and nobody knows what is going to happen. So I know this is a little bit kind of stupid. You think nothing is going to happen, and I really hope I teach you this for nothing, but it's better to know it than to regret it. So let's learn how to make iodine. First of all, you know the one for wound? The iodine for wound. Iodine for wound. This guy. Yep, this guy. So what I want you to do is something like this. You get 100 mcg, okay? Like almost the whole bottle, 100 mcg of this, and you put it inside of a tube. Okay, it's red, right? This is toxic. Do not drink it. If you drink it, it's toxic. It's bad for you. So what should I do? What should I do? What should I do? The next step that I want you to do is something interesting. You know what is ascorbic acid? Does anybody remember what is ascorbic acid? Ascorbic acid. Yes, I am recording. Ascorbic acid is vitamin C. So you will get some vitamin C and you will add up the vitamin C into this mixture. Okay? Just get 1, 2, 3, 4, 5, 6 tablets. Each tablet normally has around 500 milligram. So we are putting 3 grams of vitamin C and 100 mcg of iodine. So what is the next step? The next step, you need to add 1 tablespoon of salt. So around 10 grams of salt. So you put salt here. What's next? You mix this. Mix it, mix it, mix it, mix it, mix it. It's amazing. See this mixture? The color of it will be colorless. I know that iodine is red, but when you add the other substances into it, it will become colorless. Okay? So when it becomes colorless, this is basically going to basically do what? That's it. You have yourself iodine. You just have dissolved iodine from the whole thing. Take it, drink it. That's it. You are in a perfect situation. Give 1 serving for each family member. After you consume it the first day, try consuming it again the second day. Make sure you keep covering, especially for the genitalia and the abdominal organ and the thyroid. Try to escape that area as fast as possible. This is all of the declaration you should know regarding the this nuclear and radioactive iodine stuff. Okay, I hope that makes sense. I really hope that you will not use this. I truly do. But just in case, if you will be stuck in such a situation, you will know what to do. So let's go back to our normal topic, normal medicine. That sounds more fun. MSK. So again, for that solution, the last time it has a 3-component. What were the 3-component? Can somebody write them, please? 3-component. And with dosages, please. So again, iodine 100 mcg plus what else? Vitamin C 3 grams, which is around like 6 tabs, right? It depends, like actually from one tablet to another tablet, but it's ranging around like 6 tablets. Plus, what else should you take with them? Excellent, 1 tablespoon of sea salt or table salt. That's it. Mix them together really good. The solution will become transparent, colorless. And you drink it once a day, and on the second day, like after 24 hours, you do it once again, and that's it. And you run away from that area, okay? That's it. Try to take, and yeah, don't forget about the water. You need to take off your clothes and put in, like, keep like pouring water in yourself. If you see like this explosion in front of you, what should you do? Look to the other side. Don't look directly into it because you will be blind, okay? Don't run. Trust me, the 2 meters will not help you. First of all, you should go to the ground, okay? And when you go to the ground, try to put your head between your legs. That's the best chance you have. And the most important thing, don't look at the site of the explosion. To be fair with you guys, if you are within 2-3 kilometers, don't even worry about this stuff. You should not worry about it. If you are within 2 to 3 kilometers, if where the bomb is going to fall, trust me, you will not worry about this stuff. But I'm speaking about if you were far away from that, then you have to worry. Yeah, so that's everything you should learn about. Yep. It's amazing how these days we have to learn this stuff. It reminds me of the Cold War. So, okay, so I remember that yesterday we started speaking about the common musculoskeletal condition. We spoke about this one, this one, this one, this one, and this one as well. We did not speak about the plantar fasciitis. Plantar fasciitis, first of all, you need to know what I'm speaking about. You know, it's most commonly in old ladies. These ladies will come to you and be like, "Oh, my son, look, I have this pain in my leg. You are no doctor, understand what I have." And she's having this pain here in her heel, right? She's like, "Oh, it's painful." When is it painful, Grandma? It's painful, especially in the morning when I wake up. When I wake up and I start walking, it's so painful. But in the afternoon, it feels much better. Only in the morning, it's bothering me. Only in the morning. You're like, okay, but what if, like, you keep walking during the day? No, I feel amazing. I go dancing at night. I feel no pain. It just happens when I take some rest. After rest. So when you are active, you have no symptoms. It happens only after rest. That's correct, my son. So what is that? That's a plantar fasciitis. It's an inflammation of the plantar aponeurosis characterized by heel pain, worse with the first step in the morning or after a period of inactivity, and it's tender on palpation. It's located exactly right here. The treatment of such condition is with anti-inflammatory medication. This include naproxen, which is an NSAID, and also indomethacin. Diclofenac sodium is amazing. It reduces the pain. Do not give ibuprofen because it's too weak for the bone. Okay? Good. So the next thing, temporomandibular disorder. So, there is multiple ways this can present. But one of the ways, first of all, you need to know what is temporomandibular joint. It's the only joint that opens your jaw. Guys, when you bite something, which jaw is moving? Is it the upper jaw or the lower jaw? The mobile one. Excellent. It's only the lower one. So this is in contrast with some animals, such as a crocodile, in which they can move both. So yeah, it's going to be only the lower one we can move. Why? Because we only have one joint, this joint, right? So sometimes this articulate disc here loses a fluid or have some other problem in the muscles or in the tendon or some type of calcification. All of these can lead to stiffening of the joint. A stiffening of the joint will make the patient having hard time opening his mouth. Okay? So this can be really problematic, especially for which specialist? The answer is the dentist. The dentist wanna do, like, you know, some work in the teeth, and he's unable to open the mouth. He's like, say and he's like, he's like, say and he's like, so yeah, that's quite problematic. So a group of disorder that involves the temporomandibular joint and muscles of mastication. Okay, it's a multifactorial etiology, which means that basically we don't know exactly why it occurs. It's associated with a trauma, and like directed trauma to the joint, or poor head or neck posture, like the one that I'm doing right now. Oh my god. Okay, let me correct my posture. Basically, I was having my laptop in front of me, and I was like, my back was like this. Oh no, where is, yeah. Basically, this is my laptop. It was here, and I was like, I'm sitting, and yeah, I'm leaning like this, looking at the laptop. Okay, so this is a really bad posture to have. Why? Because my neck is horrible. My jaw is like the Godfather type of thing. So it's not the best posture. Okay, and abnormal trigeminal nerve pain processing. Good idea. So I will do it during the break. So they say trigeminal nerve pain processing and psychological factor. You might finding interesting that the most common between all of these is, what do you think? Stress. Absolutely correct. The psychological factor. So these patient, I feel like somebody was joining and then escaped. I'm not sure. Well, anyway, the psychological factors go something like this. These patient, basically, when they are stressed, what do? You have your teeth always like against each other, especially when you are sleeping, okay? And you have like this teeth are exactly, you lock your jaw and like, it's like you are angry, or even when you are stressed, you are like, you are always closing your jaw. So you might think that this is benign. I mean, that's nothing. But the only problem that in the joint, you are occluding it all the time and making it immobile during the night. I mean, during the night, you should be like, your mouth should be open and relaxed. But here, it is going to be, somebody write it's after amphetamine for ADHD, which is absolutely correct. These patients tend to have this paroxysm, we call it, in which they have their teeth biting on their teeth and squeaking them against each other, making the sound of I cannot make that sound, but yeah, you get the point. So yeah, okay, so it presents with a dull, constant, unilateral facial pain because of the constant contraction that worsens with jaw movement if you try to move their jaw. Sometimes if you try to open their mouth, so if we say that this is their oral cavity and this is their jaw, you would try to open it. It normally should open like to this, but it can open just a little bit, right? So yeah, that might be problematic. So they can have also otalgia, which is a pain in the ear. And why? Because it's near the joint. Headache, because of the joint. Temporal headache. And temporomandibular joint dysfunction, which include limited range of motion, which is mostly why the patient comes to you, because he cannot eat normally, or I'm sorry, but it is also could be during to some sexual disorder as well. this is actually a presentation. When the patient comes complaining of that, how can you help him? There is some techniques that you can do it, and if that does not work, there is some exercises you can do to the patient, and if that is not possible, you can go to the next step, which is something that can relax the jaw muscles. What do you think will relax the jaw muscles? Which medication? That can be injected locally and lead to relaxation. And Brad Pitt love it. The answer is Botox. Okay? You give Botox inside of the muscles, which relaxes the jaw, and the problem ends. But before you do that, it's considered as an invasive procedure. So what you should do? You should tell the patient to start meowing. So there is something called the meowing technique. Okay? So the meowing technique, it's a technique that you teach your patient how to do it. I will not go into details how you do it. It includes movement of the tongue and others. So for example, you have this patient that have this curvature of the jaw. You can convert it to become like this. Only by exercise? Yes, only by exercise. Are you meaning that I can convert this into this? Yes, you can. All by exercise. How? By mewing. How often should I mew? You should keep mewing until 3 to 4 months and you will get this. What is mewing? If you want to learn more about mewing, watch a video about exercises about how to mew. Yeah, this guy do it perfectly actually. I'm going to send you this, basically the link, and you can watch it after the class. He basically do some mewing for you. Yes. Okay, good. That's temporomandibular joint disorder. Now let's speak about radial head subluxation. I once treated a patient with this in like a relative village, and everybody thought I was a god. I'm not a god. It's pretty easy to treat this. First of all, let's know what that is. Radial head subluxation. It's basically the story that happened. I was sitting and a lady came, a 16-year-old lady with her brother, who's, I don't know, maybe he was like really, really small boy, maybe 4 or 5 years old. And he had his hand like, yes, it was like this. It was flexed to the inside, and he was crying. He was not letting anybody touch his hand because it was really painful. And yeah, something like this. His hand was like this, okay? And it was really painful and all of that. So I asked his sister, what happened? Why he's having his head like this? Did you hit him? She was like, no, I just pulled him, and then this happened. So look what happens, guys. At your radius, not the baby radius or the child radius here, there is a ligament around it called the annular ligament. Okay? Can you see it? The annular ligament. In us adults, this annular ligament is quite tight. So it holds the radius quite strong. But in a baby, it is a little bit kind of saggy. Okay? Because it's a little bit kind of saggy, when his older sister basically pulled him from his hand, what she did? She removed the bone from the ligament. So do you need hospitalization for this? What do you think? And consultation of an orthopedic and probably surgery? No, it does not. You can treat it right away in the clinic without any serious, like anything. This is actually the interesting thing. It's like when his father saw this, he started freaking out because his child is crying because of the pain, and his hand is like this, and it's like, nobody touch my hand. I was like, give me your hand, and he does not want to give me his hand. So when you have a child and he refuses to give you his hand, what you should tell him? For children, they like to be persuaded, okay? You should learn this. Children like to be persuaded. Don't force them to do anything. You will have less luck of doing so. Tell them, look, if you do this, I'm going to give you that, okay? So I told him, look, if you are going to do this, I'm going to buy you sweets. And actually he was like, how much is sweets? Interesting boy. Anyway, so I grabbed his hand, but not like this. I did not do this procedure. I did the handshake procedure. So basically you handshake him, you just put your hand inside of his hand, and using your other hand you stabilize it from here. So you stabilize with one hand, with your it was his other hand, so it's not like this, but basically I hope you get the concept. With one hand you hold the elbow, and with your other hand you shake his hand, and then hyperpronate it to the inside. Okay, so what are you doing by doing this procedure? You are basically re-entering the bone into the socket. Okay, you are re-entering the bone into the socket. So when you do so, the bone is back into the socket. The compression of the nerve that used to be is not anymore. So the pain disappears suddenly. So the patient or the baby feels a quick relief. And you will hear a popping sound, which is basically the bone getting back into the socket. And yeah, the moment you hear that, done. You have completed the procedure and the baby is all right. So yeah, mostly it happens because somebody pulled him. So I actually see like parents sometimes doing this with their children. I'm like, what the hell are you doing? This is bad. Don't do this with your child, okay? And don't do this. Also, it's bad idea. No, don't do that. So what should I do then with my child? Well, just not this, okay? Okay. So yeah, that's basically the radial head subluxation. How to treat it? Just hyperpronate the hand. End of the story. You will be fine, and the baby will be fine, and his father will be so happy and will start to tell everybody that you are a doctor. And that will become really annoying because everybody will start calling you. So also called the nursemaid elbow. Common elbow injury in children under 5 is caused by a sudden pull on the arm. Immature annular ligament slips over the head of the radius. This does not happen in us adults because our annular ligament is much more mature and much more tight. Injured arm held in a slightly flexed and pronated position, which looks something like yeah, something like this. They will be having like their hand a little bit flexed and to the inside, and they are like just having it. It's like I feel like they are little kitties with a broken hand. They just keep it close to them, and they don't want anybody to touch it because it's really yeah, here this guy. So yep, a little bit of a flexed elbow with a pronated wrist. You need to do what? Hyperpronation of the wrist with full flexion of the wrist. Okay, you fully flex it and then fully extend it, and that's it. You have a healthy child. Okay, so that was radial head subluxation. The question will be about the annular ligament. So what is the problem? Annular ligament. The next disease is about Osgood-Schilter disease, also known as a traction epiphysiitis. This disease happens basically due to constant traction of the ligament. So Osgood-Schilter disease. Most likely it will be in people who do sports, especially basketball, guys. Basketball, okay? Why basketball? Because people who do basketball, what do? They jump a lot, right? So it's in jumpers most likely. As you can see, there is a traction lesion and actual minor fracture here. So it's going to be really painful, but the pain is going to be localized at the anterior portion of the knee. If it was at the lateral portion of the knee, this is iliotibial syndrome. That's different. We spoke about this yesterday, if you remember. Iliotibial band syndrome. That's lateral femoral epicondyle. This is different. In Osgood-Schilter disease, it's anterior, not lateral, anterior. Okay, so yeah, it's also called traction epiphysiitis, an overuse injury caused by a repetitive strain and a chronic avulsion of a secondary ossification center of the proximal tibial tubercle. Most likely, it will be in adolescent. Adolescent are people like age 12 until 18. After a growth spurt, you know when you went to school and you were an adolescent, you went back to summer vacation, came back, and you had this growth spurt in which you become longer by 30 centimeter. Yeah, that's the growth spurt. So yeah, commonly in runners and jumping athletes. Which sport contains both a lot of jumping and a lot of running? What do you think? I hope you are thinking about basketball. Absolutely. So it presents with a progressive anterior knee pain. Yeah, so the pain will be here, but the pain is important here because it will be pointed, you know? So most, like in other diseases, they will be like, oh, the pain is in my knee. But they will be like, no, 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 no. It's exactly here in the tibia, okay? It's exactly at this point I can feel the pain. It's not diffuse. It's exactly at one point. Okay, speaking of the devil, let's speak about the patellofemur syndrome. So I just want you to notice, first of all, this is the patella, and this is the ligament for the quadriceps femoris, and this is the ligament that goes to the tibial tuberosity. So in case of Osgood-Schilter disease, the problem was here. Now we are going to speak about the patellofemoral syndrome, which is an overuse injury that commonly presents in a young female athletes as an anterior knee pain. Okay, but it's interesting. It occurs after prolonged sitting, especially in a young lady that is a little bit overweight. Okay, and this overweight lady tries, for example, like she is a little bit overweight and she decides to reduce her weight. Okay, and because of that, she started practicing a lot of sports, but she excessively goes into sport. So suddenly, from a person who does not do it a lot, now do it a lot. And after that, she relaxes, quote unquote. So when she relaxes, she's going to sense the pain to the back of her patella, okay? Not at the anterior tuberosity, it will be behind her patella, so she will feel it to be diffuse, okay? Osgood, it was at an exact point. Patellofemoral, it's a little bit more diffuse. Okay, and it does not occur. So Osgood after exercise, patellofemoral after sitting or weight bearing on a flexed knee. So yeah, basically that is how it goes. So let's try to think about the diseases we spoke about the knee. So far we spoke about the iliotibial band syndrome, that was lateral pain. We spoke about the Osgood-Schilter disease, that was like an exact pain at an exact location. Patellofemoral, it was diffuse type of pain. Developmental dysplasia of the hip, guys, for the step one, can be a little bit like not the most high yield topic, but for the step two, for sure you will get a question about this. I highly advise that you study it now, and just because it's the same in step one and step two. So abnormal acetubulum, if you don't know what is acetubulum, it's okay. So the pelvic bone, consists actually of three minor bones. So you have the ilium, the ischium, and the pubis. So ilium, ischium, and pubis. In between all of these three, there is this structure. Can you see it? So this structure is called the acetubulum. Okay, this is the acetubulum. So the acetubulum, what do you think goes inside of the acetubulum normally? The femur, absolutely correct. So inside of the acetubulum, normally goes the femur head, right? Just sits in it. So, good. So now what we will have, developmental dysplasia of the hip. So abnormal acetubulum development in the newborn. Risk factor include breech presentation. What is a breech presentation? A breech presentation, it's, well, basically this is, again, mostly step 2 type of material. But there is different type of a presentation for the baby. Exactly. So we have something, So this is breech presentation. Personally, I think about it butt first. What do I mean by butt first? Most of the time, what should come out first in a baby? What should go out first? A head, exactly. The head should go out first. But in case of a breech presentation, he gives you his butt. So it can be multiple types and different types, but breech presentation, actually it's no fun actually, because it's risky. There is many problems that can occur. By the way, if you have a twin in the same bag, okay, and they are located in such fashion, I mean one up, one down, would you do a C-section or you will wait for normal delivery? Guys, if it's in the same sack, So I'm saying it's in the same sac. If it was for like this, absolutely, this is no problem. You can do like vaginal delivery with two babies like this because both of their head is going down, right? I mean, the first baby will be out and the second baby will follow him. No problem. But this is dangerous. Never do it. Never do a normal delivery like this. Why? Look what will happen. Actually, I hate to say that. I hate to teach this topic, but we must. To teach you that you should not do it. So what happens here is something like this. The first baby head is like this. I'm just going to make the babies like 9, okay? And the second baby is going to be like this. So, look what happens. And the vagina is like this. Can it fit both of the babies? The answer is not. Okay, so look what sometimes happens. The baby is trying to go down, right? Look what happens. Boom. Shit. So what just happened? The head got stuck by the other head. So the two heads are next to each other and you cannot pull the baby, right? It's too late for a C-section. You are like, shit, okay, so what can I do? It's the most severe type of treatment. You can save only one patient. So it's for you to decide as a doctor which baby should you save and which baby you should kill. You are like, why I cannot just do a C-section? Basically, it's too late. The amniotic fluid sac has opened. The baby is half of it out. And soon after the umbilical cord will stop the perfusing, you just have less than a minute for the baby to die. You need to act quick. So actually, I'm really sorry to tell you this, but the treatment is like this. You must separate the first baby head, cut the head of the first baby, remove it, and take the second baby alive. As you can see, this is something you don't want to do. So, exactly, you must know that it exists during the pregnancy, and it's super easy to know that with an ultrasound. So, if you know something like this is in the woman, will you wait for her to deliver on her own? The answer is absolutely not. On the week after 32 weeks of a pregnancy, be like, hey, cool lady, come to me. I need to deliver the baby from you. With a C-section, right? With a C-section. If it's in the same sac, two babies inverse to each other, C-section. Don't try vaginal delivery. It just, you are going to kill one of them. So, that's the problem. So less developed nation, actually this is exactly how they put it. Less developed nation, the moment they deliver the baby, most of them don't even know that this condition exists in them, you know? They just know on the day of the birth. Some of them don't know the sex of the baby until the day of the birth. So they will not know that this exists. So sadly, one of the baby must be killed for the sake of getting the other one alive. But if it was something like this is horrible. But still, it's much better than the 69 presentation. That one is the complete worse. In the same sac. Okay, anyway, that's for reproductive. So developmental dysplasia of the hip, it's mostly in a breech presentation baby. It results in a hip instability or dislocation because the acetubulum is not normal, which leads to abnormality and difficulty of fitting the femur head into the acetubulum. So commonly tested with something called the Ortlani or Barlow maneuvers, which is a type of maneuvers that can help you detect if you have developmental dysplasia of the hip. So what do you do? So I would like to show it to you. Ortlani test. So the Ortlani test goes something like this. You bring the baby and you hold both of his thighs. And after you hold both of his thighs, you try to basically move them outward, okay? So when you try to move them outward, it looks something like this. Just a moment. Okay, guys. So, okay, this is the hip. Now you open both of his hips like this here. And you try, okay, exactly. So you try to open it up. When you open it up, you will hear what? Clunk. Okay, see what he did? Clunk. Why it was removed easily? Because he has developmental dysplasia of the acetubulum. The acetubulum is not developed normally, which allows to easy escape of the femur head from there. So that's the Barlow test. What about the Ortlani? It's another type of test, but basically you are doing it vice versa. Instead of pushing like outward, you are pulling it from the out inward. So you are putting it back into the socket. Okay? The Ortlani put it back into the socket. Barlow take it out from the socket. In both cases, what you will hear? Clunk. So you will hear a sound. That's a clunk. Okay? So anytime you hear the clunk, this is developmental dysplasia of the hip. Okay, how to treat it? Do nothing. So it's confirmed by ultrasound. Why not X-ray? X-ray can see it. But basically, we don't like to do X-ray for babies because of ionizing radiation. So X-ray is not used until 4 to 6 months because cartilage is not ossified yet. Plus, so two things. The first reason, ionizing radiation sucks. The second reason, do you remember, guys, when I told you about the endochondral ossification? Yes, so basically that was cartilage that then becomes bone. So this process did not occur yet, so the X-ray will not be able to see cartilage, so you will see nothing. So a slipped capital femoral epiphysis. Oh no, I missed something. Okay, I missed this one. Leg calf Perthes disease. Okay, it's a fancy name of saying what? A vascular necrosis of the head of the femur. You cannot believe how common is that becoming these days. Why? Because we consume drugs that we should not be consuming. So let's take a look at this. Basically, this is a vascular necrosis of the head of the femur. So the head of the femur itself is dying. Why it's dying? Because the blood supply is getting compromised or so many other causes. So let's take a look. In this case, they mentioned the idiopathic one, but there is other causes. So a vascular necrosis of the femoral head commonly presents between age 5 and 7 with an insidious onset of pain that occurs suddenly that may be cause the child to limp. So they cannot move normally, they keep limping, right? More common in males, and the initial X-ray will often be normal, but the pain is characteristic. Other conditions that can lead to this avascular necrosis of the hip, except of the idiopathic cause, include sickle cell anemia, Gaucher disease, heroin intake, cocaine intake, and some HIV drugs. Okay, so multiple things can lead to avascular necrosis of the head of the femur. You are like, okay, so how can I see a vascular necrosis of the head of the femur and know that it's a vascular necrosis of the head of the femur on a CT scan? Easy. So how easy? Super easy. Let me just show you not the CT, the X-ray, then we will go further. X-ray. Okay, so when you look at the head of the femur, it will look like somebody was eating on it. Can you see? It's destructed. See? It normally should be a perfect dome. Now it's not a perfect dome anymore. It looks like destroyed. Why? Because it undergone the process of necrosis. I hope you can see how there is multiple, like, whoop, whoop. This is basically the signs of avascular necrosis. Okay, everybody. So let's take a small break for now, and I will see you after 10 minutes. Okay, everyone. So, Okay, everyone, welcome back. So let's continue. Please mute yourself. And yeah, let's see. Somebody forgot to mute himself. Okay, good. Okay, so now we speak about the slipped capital femoral epiphysis. Guys, remember when you had this scoop of ice cream inside of your cone and suddenly it fell down? Yeah, it's quite demotivating. So this is exactly how this looks like. Slipped Capital femoral epiphysis. Just a quick advice for everybody. If you have a car, fill it with gasoline today, because tomorrow it's going to be expensive. So you can see how the femoral head is falling down from the basically the femur. So this is basically the slipped capital femoral epiphysis. It looks like the ice cream just fell down, right? It's like an ice cream cone. Okay. Yep. Something like this. Okay. So they say, classically presents in an obese, I repeat it, obese, young adolescent that with hip or knee pain and altered gait. Increased axial force on the femoral head will lead to the following: epiphyseal displacement relative to femoral neck. So basically, most of the time, it's going to be a really obese young patient that was forced into going into heavy sports like American football. Epiphysis displacement relative to the femoral neck, which look like a scoop of ice cream slipping off the cone. It's just like I showed you. It's diagnosed via an X-ray, and you can see how the head of the femur is just slipping down, right? Also here you can see it. Can you see how it's slipping down? This is basically the slipped capital femoral epiphysis. Okay, so the next disease we are going to speak about is going to be as follows. So we are going to speak about the, types of fracture, pediatric fracture. What is the most common bone to be fractured in, babies? The clavicle, that's correct. The clavicle is the most common one to be fractured in babies overall. Okay, good. So we have something called the green stick fracture, and we have something called the torus fracture or the buccal fracture. The green stick fracture, that the bone is fractured but not all the way through. It's like if you have a green leaf, and you try to break it, yes, it will break, but it will not separate from each other, right? So incomplete fracture extending partway through the width of the bone. So as you can see, it's broken, but still, it's in the same location, right? It's not divided into two portions. Bone fails on tension side. Compression side intact compared to the torus fracture. In the torus fracture, the whole thing will be just 100% fractured. But if we are speaking, sorry, that's a little bit different. I made a little mistake, so let me go back. Grain stick fracture, it's basically when you have a grain stick and you try to break it down, but it does not break down 100% through. That's a grain stick fracture. So you can see how it looks like here that you do have a fracture. So it's not going all the way through the bone. So the structure of the bone plus or minus is still the same. Right? Can you see how it looks like? It's not 100% through. That's the idea. So they say it's incomplete. It's most likely after a bending type of stress. And basically the bone will be bent like a green twig. Yes, that's what I was looking for. So as you can see, this is a green twig. And when it broke, it is going to look like this. Okay. So the torus type of fracture. So the torus type of fracture is a little bit different. It's axial force applied to an immature bone or a young bone. The cortex buckles on compression, a concave compression to the side, and a fractures. So it looks something weird actually. It looks like when you just look at the bone, what I used to do is something like this. Just follow the bone. Boom, poke. See the convex shape? So it just like you go boom, and then suddenly there is little jump. This little jump represents the fracture. This is a torus fracture. As you can see, there is like if you try to look for an actual fracture, it does not exist. It's like it's a fracture, but it's from the inside of the bone. Okay, so from the inside of the bone. Okay. What do you think? Which of the following fracture will take more time to heal? Is it a full type of a fracture, or like, I mean, the whole bone a complete fracture, or a green stick fracture? Yeah, of course, total fracture will take much more difficulty for the sake of, um, yeah, healing. Again, I repeat, the torus fracture, there is no actual penetration of the bone. It's just an internal fracture. The grain sticky fracture is just a partial fracture with the rest of it just bending to the side. Complete fracture, it's the whole bone is fractured. So the whole thing, just a little bit and just a twisting of the bone. The next disease is super important. It's achondroplasia. I always remember like there is one famous surgeon who has achondroplasia. And also if you watch Game of Thrones, there is one guy there who has achondroplasia. So let's take a look at that. I forgot the name of the character in Game of Thrones. But basically this patient looks like this. They have a really big head. And in addition to the big head, they have this frontal bossing, okay? So what's up with the frontal bossing? Their head is going forward, as you can see, and their forehead is massive. In addition to that, they tend to have like this type of finger. Okay, so each two fingers like to be attached to each other in this patient. Okay, so yeah, these are the guys. So achondroplasia, it's a no fun disease, not because of the musculoskeletal abnormalities, but because of its association, okay? So let's take a look at it. And the fact that you are going to give it to your children, if you have it. Okay, so failure of longitudinal bone growth and endochondrial ossification. Remember, endochondrial ossification, we had to have chondrocyte that then gets converted into a wavy bone, and the wavy bone then gets converted into lamellar bone, right? So cartilage, wavy, lamellar. Okay, so these patients have failure of this to happen, so they will have a pretty short limbs. Membranous ossification is not affected, however. Remember, membranous ossification was directly bone, right? Directly wavy bone, then lamellar bone. No cartilage in that process, in the membranous ossification. So if you get a question about achondroplasia and they ask you which process was defective, and they give you both endochondrial ossification and membranous ossification, please write that endochondrial ossification is the one defected. Membranous ossification is totally okay. Okay, so constitutive activation of fibroblast activating growth factor 3, so FGFR3, which actually inhibits the chondrocyte proliferation. Think about it. If you have a lot of fibroblast growth factor receptor 3, and that guy inhibit the chondroblast proliferation, which process is going not to happen? So if you don't have chondrocyte, can you do endochondrial ossification? If you don't have chondrocyte, you cannot. If you don't have endochondrial ossification, can you get long limbs? I mean, your limbs grows? You cannot. If you cannot get your limb to grow, you will be like shorty. Okay, so around 85% of the mutation occurs sporadically. Autosomal dominant with full penetrance. What does it mean, penetrance? Anybody remember what does the concept of penetrance mean? Penetrance mean, yeah, it's 100% here. Well, penetrance means that if you do have the genotype, what is the chance of you getting the phenotype? If it is 100%, that means that every time you have the disease, every single time you have the genotype, you are going to have the phenotype, okay? So, next thing goes as follow. They say, it has full penetrance, which means if you have the genotype for 100%, you are going to have the phenotype, right? It is associated with increased paternal age. I mean, when the father like make the mother pregnant, he's old. What about when we have increased maternal age? Which disease is the baby at risk at? Down syndrome, absolutely Down syndrome. I'm not sure about autism, I have to check for that, but for sure it's Down syndrome. So the most common, short-limbed dwarfism. So you can take a look at this, guys, and you can see how short they are. So, really, I'm not kidding. There was a character in Game of Thrones who had it. This guy. Yeah, that guy. So, and let's take a look here. That was achondroplasia, so the defect was in the fibroblastic growth factor receptor, which is basically going to have a gain of function type of a mutation. So you are going to have more of it, and when you have more of it, you are going to inhibit the chondrocyte, and when you inhibit the chondrocyte, you will not have an endochondrial ossification, and when you don't have endochondrial ossification, what you are going to get next? You are going to get short limbs, and the baby, well, the patient is going to be shorty. Okay, so the next thing, it goes as follows. They say about osteoporosis now. Osteoporosis is becoming more often every single day. Why? Because of freaking sunscreen, and people don't. Actually, it's not only because of the sunscreen. It's to be more fair with you guys. The true reason why osteoporosis is becoming more common, it's because the people is living more. And why the people is living more? Because the medicine is getting better. So osteoporosis is a disease of the elderly. Okay, so trabecular or a spongy and cortical bone loss mass despite normal bone mineralization, and the lab values will be also normal. I mean, the serum calcium and the phosphorus will all be normal. So this disease is most commonly due to increased bone resorption related to decreased estrogen and old age. So it's a tear or wear type of situation. It's most commonly in the elderly patient. Elderly is defined as somebody who's older than how much? 65. Yeah, I hate when somebody is 55 and he says like, I'm old. You are not. 65, you start getting old. Back in the time, people used to die at age 50 because of poor medicine. But now medicine is good. The middle age, like the age that you expect to die in a developed community, is around 84 years old. So even when you are 65, you have 20 years to push. That's a lot of years. So they say as follows. Most commonly due to increased bone resorption related to less estrogen in the elderly and old age. So most commonly it will be in a postmenopausal woman. It can be secondary to drugs like steroids, alcohol, or anticonvulsant / anticoagulant therapy and thyroid replacement therapy. They really like the alcohol for this disease and the steroid, especially the steroid. Other causes include hyperparathyroidism, which lead to bone resorption, and hyperthyroidism as well, which increase the metabolism of the bone. Multiple myeloma can lead to osteolytic lesion, and malabsorption syndrome, which decreases the vitamin D. Anorexia as well, because the patient is going to have less vitamin D and less calcium. The next thing we are going to speak about is how do you diagnose it. You diagnose it by something that can check for the level of mineralization of the bone, which is a test called DEXA scan, which is a dual energy X-ray absorptiometry. So this test goes something like this. Normally, you should have your DEXA scan test testing 2.5 or more, which means like could be -1, 1, or 0 even, no problem. But if it was less than -2.5, I mean it was -3 or something like that, that's mean that you do truly have an osteoporosis case. So they say DEXA scan at the lumbar spine, total hip, and femoral neck with a T-score of 2.5, okay? Or by fragility fracture. What is fragility fracture? It's somebody that has, like, you know, he fell from his height, he just like tripped over something and fell, and he broke 3 bone. Does not make sense. How can you break 3 bone from just falling minimal, exactly, from a minimal trauma, you break multiple bones? Because you have osteoporosis, okay? So they say something as follows. One-time screening is recommended, especially in females after the age of 65. So what about men? We men always have testosterone, which protect us. Estrogen is much better than testosterone, actually. Happy Women's Day. Your estrogen is better than our testosterone for protection of our bone. But it's still, it just reaches an age and then it starts declining, while testosterone is always like stay in our body. It might decline a little bit. By the way, guys, you remember what is libido? Libido. What is libido? Sexual desire. Which hormone mediates it in women? Excellent job. It's testosterone. A lot of people answer it as estrogen. It's wrong. It's testosterone. Good. Okay, so prophylaxis requires a weight-bearing exercise and an adequate calcium and vitamin D intake throughout the adulthood. Yes, you will tell the lady, yes, lady, listen, just uncover your hand and try to sit under the sun. Don't wait, if that is not a possibility, take vitamin D. Weight-bearing exercise, especially of the quadriceps muscle of the leg, that will make your bone and muscles much more stronger. When your muscles are much more stronger, even if we are speaking about bone pain, when the muscles is much more stronger, they are going to handle the joint in a better fashion, which will ease up the pain. So the treatment include bisphosphonate, which inhibits the osteoclast, teriparatide, which basically work in the parathyroid hormone, and it's going to speak about it more even. An estrogen analog, because estrogen is amazing for us, known as the SERMs. And calcitonin sometimes, which is a hormone normally made inside of our thyroid gland that lead to calcification of the bone. Denosumab is a monoclonal antibody against the rank L. I hope you remember the function of rank L. The rank L used to bind to the rank to activate the osteoclast to lead to the bone resorption. So if you are inhibiting it by making an antibody for it, can you destroy the bone? Can you resorb the bone? No, you cannot. Exactly. Good. So they say it can lead to vertebral compression fracture, an acute back pain, and loss of height as well, which can lead to kyphosis. You know, this older lady, maybe you've seen her somewhere and she having this kyphosis. Please know that kyphosis is something like this. Scoliosis is when you go to the side. So kyphoscoliosis is when both of them is occurring together. Let me show you kyphosis. Kyphosis. Yes, can you see this? The older lady is just like, yeah, exactly. You know, when you were little, you always saw your grandma to be really tall, and now when you are older, you see her to be really short. This is for 2 reasons. Well, they get this scoliosis, so they become looking shorter, you know? That's one thing. And also they like, see, she was this height now, and also you become taller. It's your fault. So it can lead to vertebral compression fracture. So this lady like will not have a trauma, but will have a fracture of her vertebrae, and she will actually have pain. Acute back pain, loss of height, and kyphosis also can present with a fracture of femoral neck and the distal radius, like a colon fracture. A colon fracture, it's I hope it's mentioned. I think there is a topic about that, but just in case, I will show it to you. So the colon fracture looks like this. mostly happens at the distal portion of the longitudinal bone, especially on the hand. It's basically somebody who just fractured his hand upon falling on it, okay, and having his hand separated out when he fall. And by the sides, yes, okay, that's good. So you can see how it is fractured here, and they make it, they say it looks like a fork or like a spoon. So it's a complete type of fracture. Colles fracture. Okay, guys, how long does it take for an old lady to heal this bone? Is it the same for a kid or more? Longer. This is not USMLE. This is something you will see in your life. How to calculate how many days it will take to heal a bone? So there is a formula. Yeah. So there is a formula. The formula says 7 days multiplied, plus the age of the patient equal to the days needed for healing to occur. So let's say a patient is 10 years old. How many days for the fracture to heal? 10 years old. 17 days, the bone is healed. That's it. Okay, let's make it more difficult. A lady is 90 years old. 90 years old. No, not 90. 97 days. 97 days. So as you can see, exactly, as you can see, like, as the older you get, the more difficult is for the bone to heal. And like after 60 years old, it just becomes like months of waiting for the sake of healing. Okay, you can see here how is an internal fracture of the bone is occurring, right? Okay, so yeah, before I forget, I just want to show you what is the lamina of the bone. There is something known as the lamina of the vertebra. So even there is a procedure known as vertebral laminectomy. Okay, so let's just take a look. This is the lamina of the bone. Sometimes we remove it in surgery. Why? Because sometimes the spinal cord, which is located within it, is undergoing a huge amount of pressure, and you want to relieve the pressure by removing the lamina. So we call this procedure laminectomy. Okay? They sometimes ask about this, just an anatomical term. So the next disease is the opposite of osteoporosis. It's known as osteopetrosis, which is hardening of the bone, also known as the brittle bone disease. So, sorry, that's not the brittle bone disease. Osteopetrosis is basically a disease in which we have thickening and hardening of the bone. So failure of the normal bone resorption, so the bone will not resorb, will not get destroyed, due to a defect in the osteoclast. So the osteoclast is not functioning. So you will have a thickened and dense bone that are prone to fracture. You're like, wait. That does not make sense. How having more bone means that means that I'm going to have more breaking of the bone. It's just not fitting. Yes, you have more bone, but the quality sucks. So you have more, just like, oh my god, look how strong he looks like, and in the end it's just the equipment is horrible. So if we speak about the osteopetrosis, it's a lot of bone. I mean, when you look at it here, it's super white. Super white means what? More bone, more mineralization. Basically, it means a lot of bone is there, but it's like charcoal, shulk. It's like shulk, you know. So because of it's like shulk, it's going to be like broken easily. It's a lot of it, but broken easily. So there will be the cause is a mutation of the carbonic anhydrase 2 or the chloride channel. Please make a note. It's a problem in the chloride channel or the carbonic anhydrase 2. It impairs the ability of the osteoclast to generate an acidic environment necessary for bone resorption. Remember when I told you up there? I told you for the osteoblast to work, it needs an alkaline environment. for the osteoblast to class for destruction, right? For the osteoclast to work, it needs an acidic environment. So a carbonic anhydrase 2 defect is going to lead to a problem creating that acidic environment, which is going to prevent the osteoclast from functioning and going to prevent the acidic environment that is needed from forming. An overgrowth of the cortical bone fill up the marrow space, which means what? Basically, now the inside of the bone, remember the inside of the bone mostly is spongy and empty and have the bone marrow inside of it. But in this case, it will be filled. Filled with what? With cortical bone. So that is going to basically lead to pancytopenia. Somebody said tear cells. Actually, I was looking for this. And apparently, yes, you are right. Sometimes they can have this dacrocytes, the tear cells, because you are compressing the bone marrow and kicking them out, right? Also, you can have extramedullary hematopoiesis, which is a production of like blood cells outside of the bone marrow. Which other organ can start producing the blood cells? Somebody write the kidney, you are right, but in a really small amount. The liver, you are right, in a bigger amount. And what else? Come on. The spleen, excellent. And also the cranial bone, right? Remember, this can lead to the chipmunk appearance, right? So that led to the chipmunk appearance in thalassemia because basically they have this, yeah, can you see how it looks like? And they have this hair-like projection coming out from their head. It's not hair. It's basically the bone marrow expansion in the skull to produce more blood cells. So it can result in a cranial nerve impingement and pulses due to a narrowed foramina. So the foramina is going to become much more narrower in the cranial nerve, which can impinge and lead to pulses of different cranial nerves. So it can lead to hearing loss, okay, because of impingement of the vestibulocochlear nerve or other problems. So X-ray shows diffuse symmetrical sclerosis of the bone, bone in bone. That's why basically it looks extra hardened. And the bone marrow transplant is potentially curative. Why? Because the osteoclast is derived from monocytes. What are osteoclasts? Osteoclasts basically are the macrophages of the bone, right? So because of that, when you irradiate the patient, you will destroy all of his macrophages, including these guys. And when you give a bone marrow transplant, you are going to give a new set of macrophages that will not have this carbonic anhydrase mutation, which means that the new macrophages, the osteoclast, they will be functioning normally in resorption of the bone. So that will be curative. Osteomalacia versus rickets. Both of them are due to vitamin D deficiency, but osteomalacia for adults, rickets for children. So it's a defect in the mineralization of the osteoid. They actually ask you exactly about this. In vitamin D deficiency, what is the problem? It's problem in the mineralization of the osteoid. So, or cartilaginous growth plate. So they write rickets in children, that's leading to the cartilaginous growth plate poor mineralization, while the osteomalacia in the adults, that's because of the osteoid poor mineralization. Okay? So, most commonly, due to vitamin D deficiency, an X-ray show an osteopenia. Before that, the vitamin D deficiency can be because of poor ingestion, steatorrhea, poor absorption, pancreatic insufficiency, bile insufficiency, and what else? Poor sun exposure, problems in the kidney. So an X-ray show an osteopenia and a pseudofracture in osteomalacia. Epiphyseal widening and metaphyseal cupping and differing in case of rickets. I will show you this. So let's take a look about the osteomalacia. The first thing that you will notice that the mineralization of the bone is decreased. So when you take a look at it in an X-ray, it's going to be the bone that is normally should be super white. It's going to become a little bit darker. Can you see how the bone is a little bit darker here? It's because of the reduction of the mineralization. That's rickets. So also here, you can see how the hip has decreased black color. Also, you can have this frying of the bone, which is also a sign of poor mineralization. Okay, so they say children with rickets have a pathological bowing of their leg, also known as Rome. Remember the Battle of Rome? And yeah, they can have bead-like costochondral junction, also known as the rachitic rosary. I should show you this. Basically, they have normal mineralization here, but here it's ditch black, which makes why it's ditch black because of the basically the junction between the bone and the cartilage is not getting mineralized, so it's going to look more black. So let's take a look, and there is expansion of the bone. Just a moment. Want to find it, a good one. Okay, good enough, I think. Let's see. Okay, yes. Can you see the hypomineralization here? It's more blackish type of thing. Yep. So one momento. No, bad picture. I prefer this one. So you can see how it is here more blackish. Why? Because we have less mineralization in this area. Okay. So we have also craniotabes, which is like in a baby. When you push on their skull, it's going to push in. That is totally abnormal. This should not be happen. When you look at the baby, when you push at their head, you simply should not have this. Can you see the expansion of the chest? This is from the rosary. Why? Because the cartilage is not getting ossified, so the chest start to expand out. Okay, the chest start to expand out. Can you see this? This is the rosary. This is the rosary. Again, one more. This is not muscle. This is just the edge of the rib, because the rest of it is not getting ossified. This is mostly in children. So the craniotabes. Can you see when you click on the head? It just goes in. This is craniotabes. So less vitamin D means less calcium. Also, more BTH production, because you have less calcium, BTH will increase. And the serum the phosphorus will decrease because the BTH is going to waste and trash the phosphorus from the proximal convoluted tubule. Hyperactivity of the osteoblast will basically increase the ALB function. Anything that activates the osteoblast is going to increase the activity of the ALB. The next disease is known as osteitis deformitis, also known as the Paget disease. But I want to make sure that you know that this is not Paget disease, the vasculitis. That's different. This is not Paget disease of the breast. This is Paget disease of the bone. So there is the three diseases that are Paget. We have Paget with a C, that's a vasculitis. We have Paget disease of the breast, that's different. We have Paget disease of the bone. So also called Paget disease of the bone, common and localized disorder of bone remodeling caused by increased osteoclastic activity, and followed by increased osteoblastic activity. You are like, wait a second. So are you telling me that it has multiple phases? Yes. So the first phase, you will have a lytic phase in which you will have a lytic lesion in your bone. Then it's going to be mixed, both lytic and blastic. Okay, so you will have destruction and building at the same time. Then the sclerotic phase in which only the osteoblastic is working. And finally, the quiescent phase. Okay, I'm a horrible person, I know, but there is a mnemonic that I have for this. Love my sexy queen. Love my sexy queen. Okay? So love is lytic, basically. my mixed, sexy, sclerotic queen is quiescent. So actually they go one step at a time. So if you memorize this, you know who comes first, second, third, and fourth. So common localized disorder of the bone remodeling caused by an increased osteoclastic activity followed by an increased osteoblastic activity that forms poor quality bone. Shit. Poor quality bone, does that mean if I get an easy hit into it, it's going to break? Absolutely. So what about the calcium phosphorus PTH? All normal. The only thing that will be abnormal, and this will be mentioned for you on the test, is the ALB is going to be high. Why the ALB is getting high? Because the osteoblast is getting activated, right? So you will be mosaic pattern of a waving and lamellar bone in histology, which we saw before yesterday. So osteocyte within a lacuna and a chaotic juxtaposition, which I will show you now. So let's take this guy. I hope you can see the double skull here because like sclerotic and lytic in the same time. And I just want to take a look at the histology here. Okay, so this is the wavy bone. Okay, this is the wavy bone. Good. So long bone, Schalk stick fracture. Because yeah, they do have this bone, but it can be sometimes weaker, which means they just simply break. So more blood flow from increased AV shunting, and this is actually important. So they do have an AV shunt. So they are bypassing what? They are bypassing the capillaries and the what? What is it? What else? What else they are bypassing? They are bypassing the arterioles. If you are bypassing the arterioles, will you have a normal peripheral vascular resistance? The answer is absolutely no. Okay? So they write long bone Schalk fracture, Schalk stick fracture, increase blood. What is decreased? What is the question? Absolutely, it will be decreased. Why? Because you are bypassing it, right? You are bypassing it, and instead of going to the arterioles, you are going directly to the vein. And that is going to lead to what in the preload of the heart? What is going to happen to the preload of the heart? If you are going directly to the vein, you are going to... No, you are going to increase the preload. Look what is happening. So, this is the artery. I'm sorry I'm making it blue, but this is the artery. So the artery then is supposed to go to the capillary. And from the capillary, it's supposed to go to the vein. And from the vein, it's supposed to go to the right heart. And from the heart to the lung. And from the lung to the left heart. And from the heart, again, to here. So what happens in this disease that we will have like something like this, right? It's a bypass. So blood is going to go through here and to here. So the preload will be higher, cardiac output will be higher, so that will lead to increased cardiac output, heart failure. Okay? So increased cardiac output, heart failure. Why? Preload higher, cardiac output higher. SVR is low, which lead to constant elevation of cardiac output and heart failure. Okay, guys, so let me see you in 10 minutes. Continue, I'm recording. So the next topic we are going to speak about is basically embattled disease of the bone. I told you that there will be this increase in the preload. Why? Because of the AVMs. So the arteriovenous malformation is going to lead to increased bypassing of the blood from the arteries into the veins, which increases the preload, increases the cardiac output, and eventually this is going to lead to the increase in the cardiac output will lead to increased consumption of the heart of O2, which eventually lead to increased cardiac output, heart failure. Okay. Also, the patient with the Badgett disease of the bone have two complications, so high cardiac output, heart failure, and more risk of osteosarcoma. So one of the complications of this patient is actually going to be the head size. So the head size can be increased due to a skull thickening. So their skull is become more thick and they can tell you, oh doctor, my head size is increasing. There is only two diseases in the USMLE that have an increased head size. The first one is the Badger disease of the bone, and the second one you know already. What was the other disease I told you about in which the patient have an increased head size? Well, hydrocephalus in a baby can lead to big head, but you know, a baby will not wear a hat. Achondroplasia is congenital, so the symptoms will happen right away. So actually, it's going to be like in an adult who suddenly have an increased head size. Could be acromegaly. So, exactly, acromegaly. So we have love my sexy queen, so lytic, mixed, sclerotic, and equasient. And the treatment is with bisphosphonate, which is a medication that increases the mineralization of the bone by decreasing the osteoclastic activity. A vascular necrosis of the bone, which is similar to the Leg-Calve-Perthes disease, is that the only difference that here it's not idiopathic. So, infarction of the bone and the marrow, usually very painful, and the most common site is the femoral head. Why? Because it's considered to be a watershed area. A watershed area, it's when you have basically a sublimement of an area between two arteries, right? So you can see here the medial circumflex femoral artery in which it's going up, and you can see here a branch of the obturator. The area between the two is considered as a watershed area. Okay, so in case of shock, it will be the most common area to be involved. So they say due to insufficiency of medial circumflex femoral artery, the causes include corticosteroid, chronic alcohol overuse, sickle cell disease, trauma, and lupus. So all of these can lead to basically a vascular necrosis. Some of these are atypical, such as the bends. What is the bends? Basically somebody who was deeply under the water and suddenly went over the water. So he will have formation of little nitrogen bubbles inside of his blood supply, and this nitrogen bubbles can travel all over his body. They can lead to pulmonary embolism, and they also can lead to occlusion of little vessels inside of the basically the femur, like the medial femoral circumflex artery, which can lead to a vascular necrosis of the bone. Please don't forget about sickle cell disease. They love it. Leg-Calve-Perthes disease, idiopathic, we spoke about this one. Gaucher disease, which is a lysosomal storage disease that will be discussed in biochem. And the slipped capital femoral epiphysis, which was most commonly in an obese teen Asia that started to practice sport suddenly. Okay, so the next thing is a lab value in a bone disorder, big table. Remember, in an osteoporosis, you literally see nothing. It's just an old age disease. So less bone mass. This is the only thing because of older age. Osteopetrosis, sometimes you will have decreased calcium, but overall also nothing. Why? Because this is just an overproduction of bad quality bone. So dense brittle bone, calcium decreased in severe cases, and malignant disease can occur in this case. Badger disease of the bone, only the ALB will be high because of the osteoblastic activity, if you remember. And do not forget that you will have this mosaic wavy bone architecture seen in it. And this patient can have two complications, increased cardiac output heart failure, and the other one was osteosarcoma. So the next problems that you can appreciate here is osteitis fibrosa cystica, also known as osteitis fibrosa cystica, primary hyperparathyroidism. And in that case, we are having the following. The bone will be starting to break down, and the ALB is going to be higher. The calcium is going to be higher. Obviously, the BTH will be higher. This is the main pathology. And the phosphorus will go down. Why? Because the BTH, when it's high, it's going to reabsorb calcium, kick away phosphorus, right? So you are going to have something known as the brown tumor. It's because of the destruction of the bone. So fibrous replacement of the bone, and subperiosteal thickening because of the resorption of the bone. Idiopathic or parathyroid hyperplasia, adenoma, and carcinoma can cause this. Secondary hyperparathyroidism, why does it occur? For example, somebody has chronic kidney disease, and when he has the chronic kidney disease, he starts to basically have less vitamin D, and less vitamin D lead to less calcium, and less calcium lead to more BTH, and more BTH lead to more ALB. Now comes the question, how come the phosphorus is high? The phosphorus is high because during chronic kidney disease, the phosphorus is there is decreased phosphorus excretion. Thus, the phosphorus become increased. The next thing is osteomalacia and rickets. In this disease, we have vitamin D deficiency, also called secondary hyperparathyroidism. So in that case, we have less calcium, more BTH, and the more BTH is going to activate the osteoclastic cells to increase the ALB, and that is going also to, the BTH is going to trash the phosphorus in case of osteomalacia or rickets. Finally, we have the hypervitaminosis, like an increase of the vitamin. For example, somebody who has a granuloma. Can somebody tell me why in case of a granuloma we have hypervitaminosis D? Why in granuloma we have this condition? Well, basically because the granuloma can produce 1-alpha hydroxylase, which going to prevent 25 hydroxyvitamin D to 125 hydroxyvitamin D. That is going to reabsorb both calcium and phosphorus. Remember, vitamin D reabsorb both, and thus the BTH will go down. Please keep in mind that not only granuloma do that, also lymphomas can do that. Okay? Good. So I think, guys, it's a good place to stop because I really don't want to speak about tumors in a time that you are not focused. This is high yield material, so I will leave it for tomorrow. So yeah, hopefully tomorrow we'll finish this up. Keep in mind that vasculitis we discussed already, so this will not be discussed again. So I will see you guys tomorrow at the same time.